Can people hear me? There we go. I'm Amaya, this is my colleague Johnny, and today we're going to be talking about enhancing data linkage for the NHS, specifically about how generalizable are probabilistic data linkage models. So just a little bit of an introduction. We're from the data science team at NHS England, a team of about 40 of us, and we do a bit of a range of things that you can see up here. But more specifically, we're from the data linkage project. And in the data linkage project, we have Julia, who's from the data linkage hub, and the rest of us are from the central data science team. But the role of the data linkage hub is partially facilitating reliable data linkage at NHS England. And that's kind of what we're working on specifically and why we're running this experiment that we will be talking about today. And so at NHS England, we have many data sets, and they're often linked for reporting, research, and following a patient journey purposes. When you think about linkage, ideally, linkage between two data sets should be bespoke to the data sets that you're linking. However, because this is because they're designed for the demographic features that are present in those two data sets, it means that the model is adjusted to the data quality of the data sets, and a tailored method might give better results. However, because of the large number of data sets that we have in the organization, doing a bespoke data linkage method for each pair of data sets would require high effort of tuning for each method, high compute time, a high overhead of maintenance and documentation, because it has to be done every single time that you link a new set of data sets, and there's a long quality assurance process because we have to make sure we get it right. And so if we have to do that every single time we want to link two data sets, it would take a lot of work and a lot more people than we have. So our main question for today is, could we use one universal model to link all of our NHS England data sets? And so we're going to talk you through our data landscape at NHS England, to give you a bit of context. Then we're going to talk about specifically the method of data linkage that we have been working on, which is probabilistic linkage using Splink. Then we're going to look at whether these models are generalizable for all of our data sets, and finally some conclusions and future work. So I'm going to hand over to Johnny now to talk about our data landscape.
Thank you. Thanks, Amaya. In NHS England, we have many data sets, and they have varying demographic coverage and quality. And these have patient records, which need to be linked across the different data sets in order to support publications, research studies, and longitudinal studies. So examples of the data sets are hospital attendance, maternity and childbirth events, test results, research cohorts, mental health appointments, and there are many more data sets that we have. And the demographics across these data sets can vary in three important different ways. One is the data quality. So where data has been collected in a clinical environment, then it's often of a really good data quality. If it's been submitted by patients themselves, then often we find that the data quality isn't as good at all. Another difference is the demographics that are present. So probably all of these data sets contain a date of birth, a postcode, and probably a gender. But some of them contain names, some don't. Some contain things like email addresses, phone numbers, and so on. And then the final thing in which they differ is that there is a skew or a bias in some data sets. And for example, the maternity data set will contain mostly women. And these differences mean we need to take into account the differences in each data set when we're trying to link them, and it kind of makes it harder for us to find a single linkage model that could be used across all of them. But we have one really big advantage in NHS England, which is that we can link data via reference master data. So we are not directly linking two data sets to each other. Instead, we have the personal demographic service, and we link each data set to that. PDS is a list of all the NHS patients in England, and it's a curated data set. And the advantage of that is that we can link each data set to PDS, get a linkage key, which is usually an NHS number, and then that linkage key is used to link the data sets to each other from there on, which has a couple of big advantages. The first one is that PDS contains historical information for each person. So here's an example. On the face of it, we would not think that these two records match. They are evidently different people. But when we observe PDS in the middle here, we can see that there are historical names and postcodes. So Alice Jones from Leeds has previously been known as Alice Thompson from Manchester. So actually these two records can be linked. Another big advantage that we have is it helps us to avoid some false links. So here's another example. In this case, depending on our linkage algorithm, we might think that these two records are the same person. Specifically, if we allow for a single character typo in the first name, and if we allow for a single character typo in the postcode, then these are the same person. However, when we look at PDS, which is over on the right, then actually we see that these are indeed two people. We've got Graham Evans from Lancaster and Graham Evans from Leeds. So we're now able to tell that we should not link these two people together. And this example comes up a lot, especially in the case of twins. Twins obviously often have the same date of birth, postcode, and so it's hard to distinguish them in this way. And family name is the same for twins as well. So from this example, we can see a couple of considerations we need to make for linkage. It's not just a case of, do these two records match exactly? Firstly, we need to take account of slight errors like the typos in here. And also we need to account of if there are several records in the data set to be matched to that could be alternatives. These two considerations and a few other things lead us to a probabilistic approach to linkage, which Amaya is going to talk to.
I'll bring that back down. So specifically, we're going to be talking about probabilistic linkage using Splink. So Johnny's examples motivate a need for comparing more than just two records at a time, comparing large amounts of records to each other. And as part of that, we want to answer these four questions. How similar are the demographic features of records that are truly linked? So how many typos do exist and stuff like that? How common are errors in each demographic feature? How common are coincidental matches in each demographic feature? And how many true links do we expect there to be? So how many of the records in one data set do we expect to find that person in the other data set? But luckily, these questions are answered by different probabilities that are included in a probabilistic model, for which we use Splink, which is a package that is maintained by the Ministry of Justice, and it's just a package to facilitate the Filegi-Sunter model of probabilistic data linkage. So I'm now going to explain some of these variables so that we can understand a bit more about the model that we're using. So we're looking for universally applicable parameters of these four, and so that's what we want to do to be able to link with one model. So starting with the M and U probabilities, an M value is the probability that when you have two records that are real matches, the probability that that specific demographic matches. So for example, the probability that their name matches exactly will be 80% here from our data. And then the U values are the probability that if you pick two random records from the two data sets, the probability that that demographic will match. So for example, gender matching between two random records is almost 50%. And so we train these probabilities from real data for our model. The model can learn from the distributions of data. And this, there we go, sorry. These probabilities then get used they get converted into a Bayes factor, which essentially is a weight towards how likely two records are to be a match. So each demographic can contribute to this likelihood. And we can see that in this graph over here, a waterfall chart from Splink. So for example, here, the first name and the surname match, and that's a big weight in favor of these two records being a match. Their date of birth matches, again, a big thing in favor, but their postcode doesn't quite match, and that's a little bit of a vote against, but of course people can move, so that's why it's not quite a significant decrease. And their gender doesn't match, and this specific model decided that the gender not matching wasn't a big deal. So overall, it has quite a good chance of being a match. This can become more nuanced. You can have different levels to account for typos or nicknames or other sort of cultural differences. And to do this, we use distance metric hierarchies. So for each for each demographic, we have levels beyond an exact match, so that one typo doesn't mean that they immediately get kind of not considered anymore. And so the levels, for example, for date of birth that we have are exact match, a Levenshtein distance of 1, which is 1 character difference, then 2 elements matching, so date and year, or month and day, and then all other comparisons, which is essentially doesn't match. And you can see an example of how the M values work when you include these distance metric hierarchies here. So there's a 70% chance that two people's names match exactly if they are the same person, and a 23% chance that they have a 1 character difference. All of the M values sum to 1, so each level is assuming that the level above it doesn't happen. So all of this kind of background on probabilistic linkage leads us to be able to answer the question on, can probabilistic linkage models be generalizable? And we've run some experiments that Johnny will take you through.
Cool. Thanks, Amaya. So now that we've set the scene that we are using PDS as a reference data to link via, and also that we're using probabilistic linkage, which is the Splink package. We now come back to recap on our research question, which is we are trying to balance between training a single probabilistic model, training several probabilistic models, which would be tailored to each pair of data sets, and we think that might give better results. But conversely, it would be ideal to be able to train a single probabilistic model that could be applied to all of the NHS England data sets with benefits of reuse and less overheads of maintenance and documentation. So from what we've presented so far, what have we learned about whether this is possible? Well, a big reason to believe is that one of the data sets is always PDS. Now, this means that the number of true links is always consistent. So if the demographic data is of sufficient quality in the linking records, then we should find these people in PDS, because PDS is everyone in England. The other reason that we're confident this might work is that we have a consistent set of demographic features. So if we were to create distance matrix hierarchies, like we saw in the previous slide, for every demographic in PDS, then all the data that we try and link to PDS will contain those demographics, or at least a subset of those. And this is a big advantage of probabilistic linkage, is that the probabilistic model can handle that some of those values are missing in some data sets. It handles that absolutely fine. So that's 2 of the 4 parameters into probabilistic linkage that we know we can fix. But we're still not sure about the M and U probabilities. So reasons to doubt that this is going to work, particularly the M probabilities, because as we've just talked through, the M probabilities is a proxy for data quality. So if in a low quality data set, might be different to a high quality data set in terms of the M values that come out. But even if the M and U's do come different from different models, from different pairs of data sets, then we might still get away with it because the best match might be consistent across those different matches. Okay, so onto our experiment. What did we do to test this out? So we have dataset A, which is low quality patient submitted demographic data, and dataset B, which is high quality data clinically submitted. Model A is trained on dataset A, and model B is trained on dataset B. And then we want to predict the best PDS link for its own dataset, so model A to dataset A, and so on. And then crucially, we want to swap the models onto each other, so model A predicting on dataset B, and model B predicting on dataset A. With the research question now broken into 2 parts. So firstly, how different are the M probabilities? And if they are very different, does this make a difference to the link to PDS that gets chosen by each model? Okay, so some results. How different are the M probabilities? Okay, so just zooming in a little bit here, we can see that they are quite different. So taking, for example, the date of birth exact match, we get an M value of 0.7 for model A and 0.99 for model B. This means that when trained on lower quality data, the probability of date of birth matching for records that match was only 70%, whereas for the high quality data, if a record linked to PDS, then the exact match on date of birth happened 99%. And we can see a similar trend for the names and the postcodes. Okay, but still, it might be okay because the PDS record that gets predicted by each model might be the same. Okay, so what happens when we apply the models to the data sets. For data set A, we see that model A gives a distribution of match probabilities like this. So over on the right-hand side, we've got records which are predicted to strongly link to PDS. That's about half of the records. And about half of the records are over on the left-hand side, which are predicted to have a poor match to PDS. And in practice, we would set a threshold somewhere in the middle here, which would be rejecting those matches at those links at the bottom end of the scale. Model B, which is stricter because it was trained on better data, accepts slightly fewer of those data set A as a good link to PDS. Looking at data set B, we see that both Model B and Model A predict that most of those records have a good link to PDS, and that is just because the data quality of data set B is so good. They all do link well to PDS. But it's all well and good showing that the data sets, that the distributions are similar, but what we really need to know is whether the link to PDS is the same across both of these models. So here's what we'll show now. So for data set A, 96.4% of the time, Model A and Model B agreed about what their match was. So that's either that they had the same match or that neither found a match. The area of concern here is the bottom left quadrant, where the looser Model A found a match, but the stricter Model B didn't. Then moving on to data set B, which is the better quality, we found that 99.6% of the time the two models agreed. Now, most of the time that's that they found the same match, and a few cases where neither found a match. Now, the area of concern, the bottom left quadrant, is 0. Now, this is because the stricter model didn't find any matches that the looser model did. And that might lead us to think that if we do want a generalizable model that can be applied to all data sets, then we should be using the one that was trained on the lower quality data. That's if we want to maximize the number of links to PDS that we get. However, the area of concern now is at the top right, so 391 records where Model A found a match that Model B didn't. We don't want those to be the wrong matches, so we've clerically reviewed those. And now a lot of them is that Model B did find a match, but with lower confidence, so it rejected that match. And about 30 of those cases, it found a different match, but we were unable to distinguish those under clerical review. So what we need to do from that is where there are multiple close matches given a high score, we need to add some logic that would catch those and report that to the user in their kind of quality analysis. Okay, back to Amaya.
We've had the 2-minute timer, so I'm going to go through the conclusions and future work quickly. So back to our original weight scales. You know, we've got the pros and the cons of using a universal linkage model, but back to what we think would be the pros of an individual linkage model. So yes, those models are still designed for the demographic features present, and yes, they're still adjusted to the data quality of the data sets, because we saw the M values were quite different between which data set you train it on. However, our results show that maybe it doesn't actually give better results. They're so close in quality, and some of those differences could be fixed with some of our future work. So some of our future work that we're looking at is handling those multiple close matches and deciding a cutoff threshold, because currently we use 50%, but that might not be the appropriate cutoff threshold. We want to test on more data sets, including ones with demographics missing. We want to extend to other demographic features, so currently we use gender, date of birth, name, and postcode, so maybe using email or other features. We want to finalize on which data set we actually train the model. It looks like training it on the lower quality data is the way to go, but want to make sure that we make the right decision there. And then we need to scale and operationalize our model once it's finished. And currently we're actually working on a minimum viable product with a full evaluation against our quality framework. And our quality framework is really important because people's lives and health are at stake when it comes to this linkage, so we need to get it right. And so we follow a strict quality assurance framework that was made by some of our team members whose talk is happening this afternoon. So do go and check that out if you are interested. Thank you, and feel free to check out our website for more information.
That's great, Johnny. Amaya, thank you very much. So we've got time for a couple of questions. Coming in slowly. Okay, just tell you from the top. Will you publish your code? If so, where can we find it?
Okay. So our plan is to publish the code once the pipeline is a bit more finalized, and we will be putting it up on the website, putting the link up on the website once that is ready. So make sure you check back in, and hopefully it'll be on GitHub.
Great, thank you. This is one for our fellow UK colleagues. Is there a PDS equivalent for Scotland, Wales, Northern Ireland?
I don't know. Yes. Yes, but we don't work with it.
Okay, it's a satisfactory answer. Okay, there's a question from the room. If you could just say your name and where you work from before your question.
Jo Knight, Lancaster University. I thought that was really interesting and really sensible and a good decision and way to go. I do have a slight thing to mention that I think it's a bit tricky to suggest that patients more inaccurately tell you what their name, date of birth and postcode is than a clinician. And I think you need to be a bit careful about saying that patient data is more unreliable than clinical data, particularly when the clinician's going to have asked the patient for their name, date of birth and postcode. And just as we do more and more work where we talk to the public about what we're doing with their data, saying things like patients are inaccurate in the way they report it is probably not going to help. So just twisting that slightly.
Okay, great. Yeah, we'll take that feedback on board. Thank you.
Yeah, and I think specifically what we kind of meant by that is like often with the specific data set that we're working with, it was often like families submitting the whole their whole family at once, and then sometimes NHS numbers got mixed up, or other data got mixed up, or people using nicknames or not their legal names because it's their preferred names, whereas the clinical data gets checked before it gets submitted. So that's why the difference in quality. But yeah, definitely we'll make sure to keep that in mind. Yeah, 100%.
Okay, thanks. I think that, unfortunately, that's all the time we've got for questions. Thanks, Johnny and Amaya, again. I think there's a short